When was the last time you were angry, and how long did it last? What did you do? Did you scream at your friend on the phone for not being able to make your coffee meetup and hold it against them for the following weeks? Insult them for days on end on social media vaguely, knowing they'll see it? Spread rumors about them to tear them down? Then feel like you're evil later and have a mental breakdown? Sounds a little much, right? Borderline personality disorder is a disorder defined by the DSM as a pervasive pattern of instability of interpersonal relationships, self-image and affects, and marked impulsivity, beginning by early adulthood and present in a variety of contexts. Despite the horror story I started with, the friend isn't the only victim, because borderline personality, or BPD, also hurts the person. BPD is a psychiatric condition that has a neurological basis. It's not just all in your head. Documented cases of BPD only constitute a range of 1.4 to 1.6% of the general population, and yet it makes up of 10% of outpatient populations and 20% of psychiatric ward patients. It afflicts women more than men at a 3-to-1 ratio, and the immediate offspring of those with the disorder are 5 times more likely to develop it than a random person in the population. The disproportion of cases to hospitalization alone screams for us to find a way to help those suffering with it, and not just for them, for their families, their friends, their co-workers. To understand it, we need to get to the root. Neuroscience has been able to uncover the major brain regions and neurotransmitters affected by BPD: the prefrontal cortex, orbitofrontal cortex, insular cortex, anterior cingulate cortex, frontal polar cortex, amygdala, and hippocampus. Did I lose you with all the cortices? Don't worry. Prefrontal, orbito, and insular are the main parts that are severely compromised. All these structures that I listed are part of a jumbled mess of neurons and connections, looking like the wires at the back of your TV set if you have kids. These areas are critical for the regulation of emotions, self-control, and learning how to properly respond to social situations. Research shows marked differences between these regions in a patient with BPD and a neurotypical subject. This source of lack of inhibition, in terms of action and emotion, causes ridiculous amounts of negative consequences in life. The hyperreactivity that the brain exhibits in these regions causes intense and negative lasting emotions. Since the frontal lobe still develops well into an adult's mid-20s, it's malleable to trauma from the environment. Cortical volumes from patients with BPD who suffered trauma and abuse showed a 10% decrease in them when compared to neurotypical controls. This caused atypical functional activity well into adulthood when it came to associative learning. Because of the messed up neural functions, destructive behaviors are common. Now that we know the parts, let's get down to the chemicals. Testosterone, NAA, CRE, and CHO are the main neurochemicals involved. Testosterone concerns temperament and risk-taking, and low levels of NAA implicates the breakdown of neurons. Trends also include the NAA to CRE ratio and NAA to CHO ratio reduced in the hippocampus. We're still researching this phenomena. The early signs of recognizing BPD are simple. Patients start to do anything to prevent real or imagined abandonment because of their inability to be alone. For constant attention, they make threats against themselves, like suicide, and relationships normally become strained. When the environment doesn't suit their needs, they get disproportionately angry, and they start making the worst assumptions. There's a whiplash of emotion from intense anger to intense self-hatred to intense emptiness, and it's a terrible cycle. To properly diagnose this disorder, a person must meet at least 5 of 9 criteria listed in the DSM listed below. Frantic efforts to avoid real or imagined abandonment. A pattern of unstable and intense interpersonal relationships characterized by alternating between extremes of idealization and devaluation. Identity disturbance. Markedly and persistently unstable self-image or sense of self. Impulsivity in at least 2 areas that are potentially self-damaging, like spending, sex, substance abuse, reckless driving, binge eating. Recurrent suicidal behavior, gestures, or threats, or self-mutilating behavior. Affective instability due to marked reactivity of mood, like intense episodic dysphoria, irritability, or anxiety usually lasting a few hours and only rarely more than a few days. Chronic feelings of emptiness, inappropriate or intense anger or difficulty controlling anger, and/or transient stress-related paranoid ideation or severe dissociative symptoms. While other diagnostic tests can be done to pinpoint where the afflicted brain parts are, the overall diagnosis relies on the evaluator and the accuracy of the patient's recollections. The main features that evaluators search for is stable instability when it comes to relationships with others, how they view themselves, their behavior as a whole, and impulsiveness that starts early in adulthood in various different situations. One of the therapies used to combat this disorder is dialectical behavior therapy, or DBT. When therapy is successful, brain activity in these patients is altered. The hypersensitivity of the limbic regions is decreased during emotional challenge tests, and there's also more prefrontal cortex activity. The most successful therapy seems to be DBT over the course of 12 weeks, as therapy that lasted 12 months actually showed adverse effects. Another therapy approach, transference-focused psychotherapy, or TFP, relies on clarification, confrontation, and interpretation of affect-laden themes that emerge within the transference relationship. This treatment study gave rise to general improvements and gave credence to the hypothesis that TFP improves self-control. Although psychiatrists typically prescribe lamotrigine for those with BPD, new studies show that these medications only treat the comorbidities of this disorder, like depression and bipolar disorder. However, medication as a type of placebo in place of lamotrigine has also shown to be effective. DBT and TFP consistently remain the most effective treatments in this report. Lithium as a medication in another study shows reliable improvement when compared to a placebo. Antipsychotics like risperidone, quetiapine, olanzapine, and fluoxetine, and a combination of the last two, also show the same improvement. However, it is not clear whether comorbidities are involved. Again though, when combining these medications with DBT, the improvements were markedly superior. Other medication options, like antidepressants and benzodiazepines, are also effective, but not as praised and lauded as the aforementioned pharmacological options. Regardless of medication usage though, there is one common string connecting the best cases: the combination of DBT as an adjunct to treatment. With treatment experiments constantly being challenged and tested, the future for those with this disorder looks bright. While those with BPD are victims, a person should never allow themselves to become one either. If you care for a friend exhibiting these BPD symptoms, try your best to convince them to get therapy, because this isn't something that a person can combat alone. If it comes down to it and they're hurting you, you may need to distance yourself, but don't blame yourself for that. Help is on the way, and it's only a matter of time where we can all live together as a family again.